Our guest says more and more people are publicly discussing their struggles with mental illness and substance use disorder in an open and honest way that would have been hard to imagine a few years ago. He and his colleagues see this as a great opportunity for psychiatry to make a difference.
We used to scream from the rooftops about wake up, the mental illness is such an important issue. And, people were like, they would land on deaf ears. And all of a sudden, the table is completely changed. And people are screaming, we need more help, we need support, we need services, we need this and that. And we haven't been prepared to respond to this kind of demand. So we have our work cut out for us.
For the longest time, it was hard for me to even get out of the house, much less do a backside 180. It took me a bit to understand what was going on, but eventually I learned I had anxiety.
Joining us is Dr. Petros Levounis. He's the president of the American Psychiatric Association, which represents over 38,000 physician members who specialize in the diagnosis, treatment, prevention, and research of mental illnesses.
We do know that medications for opioid use disorder are safe, are effective, turn people's lives around, and yet they have not been adopted as much by a long shot by either primary care physicians, by clinicians in general, and by the general public. Still a lot of myths are out there that I don't want to substitute one addiction for another, I don't want to go on medication.
And this is Conversations on Healthcare.
Well, Dr. Levounis, welcome to Conversations on Healthcare.
Thanks so much for having me on your program.
Some really disturbing news came from the CDC and some provisional data reporting that more people died from suicide in the United States last year than any other year on record. And now you've spoken out in the past that when people are feeling suicidal, they're doubly adverse to seeking mental health support. I'm wondering if you could tell us about the APA Foundation's Mental Health Works campaign and what it intends to do.
Yes, our campaign has one major goal: to open up the conversation. Way in the past, we thought that when you talk about suicide, you may be making things worse. We know that it's not true. The more we talk about these matters, the better off we are. So opening up the conversation, having that first openness with a loved one or with anyone whom you trust is just so essential.
For the longest time, it was hard for me to even get out of the house, much less do a backside 180. It took me a bit to understand what was going on, but eventually I learned I had anxiety.
Of course, seeing a professional, seeing your primary care physician, seeing a psychiatrist is a great idea, but the majority of people who have start feeling depressed or anxious or sometimes even suicidal, they would prefer to talk to someone other than a psychiatrist at first. So this is what the campaign's strength is all about, to not just say there's one and only one path to finding help.
Well, Dr. Levounis, anxiety, of course, is a big contributor to distress that may get people to that state. And the U.S. Preventive Services Task Force has now recommended for the first time, I believe, that physicians screen all adult patients under age 65 for symptoms of anxiety. Are you and your members seeing, or are you hearing reports of an uptick in referrals coming from primary care and other physician and other healthcare provider practices? Do you think this is going to be helpful?
It is going to be helpful. It is going to be to raise awareness about anxiety disorders. But we have not really seen the effect that you mentioned yet. Maybe too early. This just happened this summer. So we haven't seen the uptick that maybe we will experience in the future. But more than the specific referrals, it's once again in the spirit of opening up the conversation and making this diagnosis much less fearsome than they used to be.
I know you're very proud about being elected as the president of the APA. What an honor. and you've chosen as the theme of your presidential year, Confronting Addiction from Prevention to Recovery. You say you don't want to just move the needle on addiction, you want the needle to keep moving. I'm wondering if you could share with our listeners, what do you mean by that, and how are you making it happen?
Yeah. I don't remember ever having a presidential theme focusing on addiction. So I thought it was time to do so. I'm an addiction psychiatrist myself. It's a major issue for our patients, for the general public. So I thought it was time to choose addiction prevention, addiction recovery, addiction treatment as the theme of my presidential year. But this is 12 months. So there is only that much that one can accomplish in 12 months. We have 4 campaigns that we are unleashing during this 12 months, and we're very proud of them. Vaping, opioids, alcohol, and the technological addictions. But it is something that needs to get going beyond these 12 months. And we already convened a group of like-minded organizations at our headquarters in Washington, D.C., and the spirit of this meeting is, what can we do to sustain these campaigns, to sustain these efforts beyond these 12 months? And I was so pleasantly surprised by how well aligned we are. All these organizations, from OBGYN, obstetrics gynecology, to internal medicine, to the American Society of Addiction Medicine. And we had really very similar goals, very similar tasks. And I do have great hopes that the addiction recovery and the prevention will continue beyond my 12 months of presidency.
Wonderful.
Well, what you're saying, Dr. Levounis, certainly resonates with those of us who are in the primary care space, certainly in the nation's community health centers, which is where Mark and I are primarily focused, because smoking, vaping, alcohol, and opioids are really what is shortening the lives of our patients and causing tremendous distress. So we are very appreciative you're taking that focus. But I wanted to talk specifically about the vaping for a moment. A study in the journal Drug and Alcohol Dependence noted that people with mental illness are more likely to use e-cigarettes and to use them more frequently than people without mental illness. That's exactly what I always said about smoking. Before there was such a thing as vaping, that was certainly well known. But many people see vaping as less harmful than cigarette smoking. How are you and APA getting the word out about this as a real concern?
Yeah, it is a real concern, exactly like you said. There is that myth out there that smoking cigarettes or vaping should be the least of someone's problems if they have a mental illness. And that couldn't be farthest from the truth. As you very well know, the majority of people who live with mental illness will not die of bipolar disorder or schizophrenia or depression or ADHD. They will die from tobacco and from vaping and from alcohol and one of those disorders. So we want to dispel that myth that, hey, if you're already mentally ill, who cares? Have a little fun, have your vaping, have your cigarette. This is an absolutely terrible message that people have been perpetuating.
Well, that's such an important reminder to all of us. I'm wondering if we could switch a little to alcohol use disorder. I'm wondering what you can share with us about some of the innovations you're hearing about. We see a lot of benefits, and I think, Margaret, we saw this from maybe the Veterans Affairs working on psychedelic drugs for treating alcohol addiction when combined with psychotherapy. What other interventions you think are promising in this area?
Yeah, the study on psilocybin by my friend Steve Ross is quite revolutionary for our field, because here you have a substance that has been viewed for decades, if not more, as a major villain and part of one of the worst addictions you can think of. And now it is being studied and shown in a preliminary fashion to be helpful in the treatment of alcohol use disorder. So it is switching positions. We're not there yet, We haven't crossed all our T's and dotted all our I's in terms of drug-drug interactions, in terms of long-term effects, in terms of pregnancy, and so on and so forth. But the preliminary results are quite encouraging in terms of psilocybin for the treatment of alcohol use disorder.
Are there any large clinical trials going on in that particular area?
There was the one that was published in 2022, and I do believe that there are more coming up. The other thing about alcohol that we do need to mention is a shift in the appreciation of outcome studies for alcohol use disorder. It used to be that only complete abstinence was something that we would appreciate as a worthwhile outcome of any treatment study for alcohol. And in 2023, we very much appreciate and respect decrease in heavy drinking as being another very desirable outcome of alcohol studies. So we have shifted our research focus on alcohol as well.
Well, we look forward to learning more about that. It is such a prominent and common problem in our patient population, really in the society at large. And one of the groups that we're very concerned about are women and young women. We're reading that women, females in their teens and early 20s, the data suggesting that they're reporting drinking more, actually getting intoxicated at higher rates than their male peers, something that we maybe had not seen previously. And I'm wondering, as you try and craft messages and policy, is there a targeted public policy approach needed that's specifically designed to reach young women in the way that we've tried to reach other particular populations of focus?
Yeah. Yes, we do. And the point there, which is very well studied, very well researched, very well established, is the concept of telescoping among women. And that has to do that, although it may not be that there are as many women who would start drinking heavily as men, once women start drinking heavily, then from the early points of the illness to the most severe form of the illness, the process is very quick. And that is of huge concern, of course, to us, and also greatly underappreciated because people just read the studies of the major epidemiological studies and they say, hey, this is primarily a men's problem, not a women's problem. And yet this idea of telescoping is particularly catastrophic for women. Adding to that, the other well-known fact that women tend to drink more in private situations, more alone. So the opportunities for red flags to go up are less than with men. Men tend to drink more in public. And so hopefully there is a friend or somebody who has seen a catastrophe coming down and they say, well, wait a minute here, maybe there's something that we can do about it. While women tend to drink more at home and when nobody else is around. Again, I'm talking about it in general here. Yeah. Of course, a lot of men and a lot of women who are drinking the other side as well. But that is of great concern to us.
I'm really fascinated by the work you're doing as editor of the book, Technological Addiction. And you say the book is really a wake-up call, alerting the medical community and society at large to the addictive potential of technology. And you've talked about gaming being an addiction, as well as cyber sex, social media, texting, email, and online auctions. I'm wondering, when do these activities reach the level of addiction, and what does treatment look like? I've also noted that we're seeing a lot of commercials now focused in on young people who are really being addicted to social media. So I'll add that in as one of those areas that is this something that the APA is also behind in terms of sponsoring advertisement or notifications about this?
Yes, we are. And may I have mentioned that we're having 4 campaigns this year, and we talked about vaping, opioids, and alcohol, but the 4th one is on the technological addictions. So the vast majority of people do engage with technology in 2023. I know I do, and I'm sure most of you do as well. And the vast, vast majority of people are not going to have a problem with technology, not with internet gaming, although we may play some games, we may engage in texting, emailing, social media, and so on. But there's a very good chance that we're not going to have any problem with it, either recreationally or professionally. It is part of life. However, there's a small group of people, maybe 3%, 4%, 5%, who will cross the line and be on the other side. And what we see with these patients is something very similar to what we see with people who live with substance use disorders. We see tolerance. We see people needing higher amounts of the same activity in order to sustain the same level of excitement. We see withdrawal. We see people abruptly stopping using an internet game and becoming irritable and depressed and anxious and suffering from insomnia, classic symptoms of withdrawal. We see people trying to cut down and not being able to do so, despite the fact that they recognize that it's not good for them. The classic major blocks of the assessment and diagnosis of addiction. Consequences, relationships going south, hobbies being ignored, professional responsibilities being put aside, medical consequences. So these are the things that we look for when we do give the diagnosis of a technological addiction. Internet gaming is being appreciated as a formal medical diagnosis by the International Classification of Diseases, and may very, very well be part of the DSM-6 of the American Psychiatric Association.
Let me just push. I just want to maybe follow up on Margaret. Thinking about, we've had Dr. Vivek Murthy on and talking about the epidemic. The epidemic of loneliness and isolation. I'm wondering if those numbers are starting to change. In the COVID environment, what are you seeing? Certainly, I think about the social media impact on young people, probably on all of us because of COVID. How is that? Is that sort of an inflection point where we have to sort of recalibrate and start thinking about the size of the wave that's coming at us?
Yeah. That's how I see that. I see that there's going to be a small number of people who actually may be bigger than 3 or 4% that I just mentioned before, who actually will meet criteria for a medical condition and will need professional help. We do know that cognitive behavioral therapy, motivational interviewing, maybe even mindfulness would be quite helpful for people who do suffer from this medical condition. And then there is the general public. There is the rest of us who engage in social media. And to me, that's a social experiment. We're not quite sure how it's going to end up. I see my 12-year-old niece engaging with social media and having an entire world that is virtual, which I couldn't even fathom of having at her age. Will these friendships be at par, better, worse than the friendships that I had when I was 12 years old? I'm not quite sure. I think that this is something that has to play out and find what we're going to see some years down the line. What we do know is that there are some significant positive effects of engagement with technology. For example, older adults are particularly vulnerable to scams and online shopping and internet engagement with people who may not have their best interest in mind. So my 12-year-old niece will have much better antibodies against those scammers than perhaps quite a lot of our older adults.
I would just add, Mark, as you were saying, Dr. Vivek Murthy, certainly somebody who has deep concern with this issue, and particularly, I'd say, about children younger than 12 who are on social media, who are being exposed to things which seem intentionally designed to keep them engaged and for periods of time that may cull out other activities more healthful perhaps for that age group. And maybe we can come back to that if we have a few minutes. But I did want to make sure to give you an opportunity to talk about another of your key areas that you're focused on, and that is opioid addiction, which we have lived through from the beginning, through the promotion of the opioid drugs, through the response to the epidemic, and of course, we're still left with the huge loss of life. I think you had a poll that showed that Americans strongly favor improving access to treatment over imposing stricter punishments, legal punishments, to address the problem. Can you share a little bit with us and our listeners about what insights you'll be bringing to this issue during your term?
Yeah. When we chose our addiction prevention to recovery campaigns, our guideline was to find areas where we have the biggest gap between what we are sure about, what science has pretty definitively concluded on, and what is appreciated by the general public. The greater the gap, the more enthusiastic we are about our campaigns. Opioids is exactly one of those areas. We do know that medications for opioid use disorder are safe, are effective, turn people's lives around, and yet they have not been adopted as much by a long shot by either primary care physicians, by clinicians in general, and by the general public. Still, a lot of myths are out there that I don't want to substitute one addiction for another. I don't want to go on medication. I just want to be clean. I want to detoxify. All these things that we have tried and we know that they are not effective, that they are more trouble than good. And we do have the answer. I mean, we do have, to me, it's as an addiction psychiatrist, there are so many substances for which we do not have any medications. For example, I'm thinking about the stimulants, cocaine, crystal methamphetamine. We have wonderful psychosocial interventions. We have wonderful psychotherapies that can address these conditions, but we do not have a medication. And then we do have medications for tobacco use disorder. We have medications for opioid use disorder that work extremely well, and we do not use them. It's such a shame.
I want to just get a little away from the addiction and come back to it, though. I was thinking about the impact that long COVID is having across the society. I know we've just had Dr. Lenore Horowitz from your old stomping grounds, NYU, who's doing a large clinical trial on long COVID. I'm wondering if there's any engagement with the APA or any of your colleagues are engaged in this, because it's the mental health component is so critical. The levels of anxieties have increased. I'm just wondering if you have any observations or intersections with the work that's going on and will be going on for a long time, focused in on the impact that long COVID is having on society.
Yeah. We do see a neuropsychiatric sequelae of COVID infection, part of long COVID. And we're particularly concerned about that. At this point, the data is significant, but it's not very specific. There are a lot of symptoms that mimic other psychiatric disorders, so we're not quite sure of what can be attributed directly to the effects of the COVID infection. What I'm saying here is that we have seen an increase in anxiety, we have an increase in depression across the board with the pandemic, but this may very well have been the consequences of the stressful situations, financial and social and professional, and all kinds of stresses that people have experienced with the pandemic. Some of it may very also be the direct effect of the COVID infection, and that's exactly what we try to tease out and become much more confident when we talk about long COVID and its implications. I want to add a third concern that we have there. It's actually not a concern, it's actually a positive thing, and that is that the pandemic has brought in the forefront the conversation about mental illness. This is something that we were not really prepared for. Right before the pandemic, people had started appreciating and discussing mental illness, but certainly the pandemic accelerated this awareness. And for that, of course, we are particularly excited about.
I want to pull the thread a little on that concept. We've been engaged in providing school-based health services for about 30 years. In mental health, we've always been saying what we want to have happen is to normalize the use of mental health clinicians, right? But today we have more and more schools calling us up and saying, you've got to come in now, which, we used to start with dental and then go to medical, and behavioral health was sort of the last rail. But now it is really, I think, really to your point, is resonating across the country. People are demanding.
That's exactly what we're experiencing as well. You couldn't have put it better. We used to scream from the rooftops about wake up, the mental illness is such an important issue. And, people were like, they would land on deaf ears. And all of a sudden, the table is completely changed. And people are screaming, we need more help, we need support, we need services, we need this and this. And we haven't been prepared to respond to this kind of demand. So we have our work cut out for us to figure out how we can respond to this incredible demand that we see everywhere around us.
Right. Well, I'm so glad you raised that point, and Mark addressed an important way that we create access through school-based health centers, but access to psychiatry, to psychiatrists, to psychiatric nurse practitioners, to therapists, obviously is huge. And if we have time, I'd love to talk with you on your thoughts of what we're doing to train enough people, because certainly in the primary care space, recruiting psychiatrists is one of the most difficult positions. But even if we were able to address that issue, we have the challenge of the health insurance plans and the restrictions. Mark, we had former Congressman Patrick Kennedy on the show to talk about health plans and how do we hold them accountable to the requirements of the Mental Health Parity and Addiction Equity Act. And I wonder if you might just tell us some of your tools and efforts to ensure that health plans comply with the law for psychiatric mental health treatment, but also substance use disorder treatment.
Yeah. I was on the phone with Patrick Kennedy a couple of days ago, and I was delighted to see how extensive a plan he has to address exactly what you're saying. And of course, the APA is more than happy to help in these efforts. I would say the APA does quite a few things quite well, but our engagement with policy is probably one of the marquee components of the American Psychiatric Association. So we do partner with other organizations. We do have the Group of Six, as you probably know, with family medicine and internal medicine, OBGYN, pediatrics, osteopathic medicine, and psychiatry. So we come together. We mentioned that we have 38,000 members, but altogether as a Group of Six, we have over 300,000 members. And so when 300,000 physicians are talking through our representatives, then the Hill starts listening. So we're quite optimistic here that by combining our voices, we will have an impact.
Let me just get to one last area. Just again, the breadth of the APA. You have a webinar about how generative AI and related technologies may affect mental health and the practice of psychiatry, and how to recognize the strengths and risk of AI-driven technology. I'm wondering what your feelings are about AI and any advice that you might want to share.
Yeah, I'm quite positively predisposed to AI, and I think that there's a lot of promise there. I do a lot of CBT, cognitive behavioral therapy, with my patients. And what I do is I give them homework, and I give them tables to fill, and I give them Excel sheets so that they can record their feelings and put grades and rate their cravings and all that stuff that are incredibly amenable to AI, to apps, to things where people can record their activities and their thoughts and their feelings, as well as follow their progression through time. What is missing is the intersection with the clinician. There are some apps that advertise you don't need a clinician at all. You can do it all by yourself. And we do not think that this is effective. We do think that you need a human being to be involved in some capacity. And these electronic devices can be wonderful adjuncts, but they cannot replace the human being. On the other end of the spectrum, there are some apps that require the clinician to be available 24/7 to the patient, and that is unworkable as well. So somewhere in between, from not needing the clinician at all to having a clinician 24/7, is the sweet spot where we're striving to find out exactly how we will combine the personal touch of a trained therapist with an app.
Well, Dr. Levounis, I want to thank you so much for joining us, and I'm just hoping we can extend an invitation to do it again sometime soon, because we have a lot more questions that we'd like to ask and engage with you on. And we also want to remind anyone who's in need of mental health support to call 988. That's the new Suicide and Crisis Lifeline. It can be a huge help to you. And thanks to our audience, as always, for being here. There's more online about conversations on healthcare, including a way to sign up for our email updates. The address, chcradio.com. Dr. Levounis, thank you for your leadership, for all that you're doing, and we look forward to speaking with you again in the future.
Thank you so much.
Absolutely.
This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.